Welcome in to Your Health. And we have again this week, and we will have all this month, Dr. Thomas Wool, who is a cardiologist. Today we are going to talk about diagnosis. We talked last week about some of the symptoms and the things for you to be looking for, and this time we're going to talk about the actual diagnosis. So let's say I come to you, I know that something's wrong, and I've done what you told me to do. I have paid attention to these symptoms, and I know that my body's not quite right, and I've gotten to your office, which is the smartest thing that we can do.
Yes.
And then you're going to make a diagnosis. How do you go about doing that?
We always start by taking a careful history. We're taught in medical school that you can make perhaps 80% of diagnoses based on the history. So we speak with you very in depth about your symptoms. And again, as we talked earlier, symptoms that are related to exertion are primarily suspicious. So we then need to take the next step in terms of trying to confirm or refute that diagnosis. So a common thing that we would start with would be a stress test. And a stress test is designed to try to detect any narrowed arteries in the patient's heart.
And that's basically putting you on a treadmill?
Correct. There's two ways to do it. There's an exercise stress test, like a treadmill. In other locales, they use a bicycle ergometer, but the same basic thing. And the other way is a pharmacological stress test. So, for example, you've had a recent knee replacement, so you can't walk on a treadmill.
Right.
You can have a pharmacological or chemical test where it's done with drugs given by vein. So, in a stress test, in the contemporary type, we usually do a radionuclide or nuclear heart scan along with the test, which improves the accuracy of the test. So then as the person exercises on the treadmill, we're looking for whether or not they develop symptoms. We're looking at whether or not their EKG shows the characteristics, abnormalities that you see in somebody with a clogged artery. And then on the heart scan, we're looking for areas of the heart that don't take up the tracer to the same extent as an adjacent normal area, which would suggest a clogged up artery.
Well, you have brought some fascinating things to tell us about.
Well, I have.
And I'm finding this extremely interesting. So would you let me know what you have here?
I will. So again, the history is very important, and the next thing we do is a physical exam, and this is one of the most important things. So it's a stethoscope, and like everything today, this is a digital stethoscope. So as long as the battery's good, it works just fine. But,
do you like it?
I love it.
Okay.
You can actually even record a murmur with this, play it back, transmit it to a colleague.
Wow.
So it's very digital.
Wow.
So again, we're going to start with a stress test, some non-invasive things. We're probably going to do an ultrasound of the heart called an echocardiogram, and some blood tests, check your cholesterol. At that point, if things are still looking suspicious, abnormal, the next step oftentimes is to do what's called a cardiac catheterization. So that's a procedure that actually lets us make pictures of the coronary arteries.
Okay.
So your heart is a wonderful organ. It's a pump. It's primarily composed of muscle. So just like any other part of your body, it has to have a blood supply to function properly. So it has three arteries: the right coronary artery, the left anterior descending, and the circumflex. So commonly we do what's called a cardiac catheterization, which is a procedure to let us make pictures. This is an actual catheter.
Okay.
So as I tell patients, it's a long, soft, flexible plastic tube, and it is inserted into the body from two areas. I do most of my heart caths from the radial artery here in the wrist. Okay. They're also done from the femoral artery in the groin. So this is a procedure done with a local anesthetic. There's not an incision.
Wonderful.
Right.
Get some relaxing medicine, but we can pass this little tube right up here to the heart, and we position the catheter right there in the beginning of the arteries, and we inject contrast. It's always called dye. It's not a dye. It's a clear, colorless liquid that allows the arteries to show up on X-ray. So this is painless, takes perhaps 20 minutes to get the basic pictures, and then we know. And depending on what we see, we'll know what the best treatment option is for that given patient, whether that be medication, a stent, or even surgery.
Wow, I love the fact that medicine has progressed to the degree that things that were just horrific to go through are not anymore. And I'm assuming is what, is it outpatient? Do you go home
Oh
that
yes,
day?
it's almost all outpatient,
Okay.
unless you've come in with an emergency
Right,
problem.
right.
You got to do something else. Yeah.
Well, it's exciting, I think, that medicine has made so much progress, is so accurate. And so if you do have a problem, don't function from fear. Don't be afraid to go find out, because something can be done. That's the beautiful part.
It is.
It is. So don't be afraid. Take care of yourself. We'll have more information for you next week, and we'll see you then.